Hello everyone, today we discuss gestational diabetes, a subject that is very interesting, and it can be difficult because of the places where we are working, the difficulties in the supplies and the kind of patients we receive. So that's what we are talking about today. Let's get into it. So the objectives of this presentation is for us to know what diabetes, gestational diabetes is, maybe also highlight how different it is from pre-gestational diabetes. We want to learn how to diagnose gestational diabetes. I want to outline its management and in the antenatal period and during delivery, and we want to also learn the options for treatment for gestational diabetes. So there's been a lot of confusion in terminology on what we should call gestational diabetes. Is it, some people would say it's a second trimester disease if we find glucose intolerance or gestational diabetes in the first trimester. We shouldn't call it gestational diabetes. There's overt diabetes, there's pre-existing diabetes, there's pre-gestational diabetes. Even diabetes in pregnancy itself has several meanings depending on what literature you're using. But for the purposes of this discussion, and maybe we'll deal with this confusion in another video, for the purposes of this discussion, we'll call diabetes in pregnancy any woman who has diabetes and she's pregnant. So we'll call that diabetes in pregnancy. We'll call gestational diabetes by its standard definition. So it's diabetes or glucose intolerance of variable severity, first recognized in pregnancy. So or of first onset in pregnancy. That's how we define gestational diabetes. We define pre-gestational diabetes as diabetes that was there before pregnancy came in. So this woman was on treatment for diabetes, her diagnosis was already made, and now she's become pregnant. That's pre-gestational diabetes, and that's not the discussion for today. Our discussion is gestational diabetes, a woman who was not known to be diabetic before she was pregnant. Now she's pregnant. We've discovered or we've recognized diabetes right when she's pregnant. So let's briefly talk about the epidemiology of gestational diabetes or diabetes in pregnancy. So the prevalence is around 15%, which is quite high. This depends on how often women are screened and how much screening we are doing that out there to make this diagnosis. Out of these, 12.8% is gestational diabetes, and a few are those patients with pre-gestational diabetes. Gestational diabetes has become quite common. This is because we have an increased number of women who are obese. We have an increased number of women who are starting to have families later in their age, and our diet is not ideal, and also the prevalence of gestational diabetes is quite different depending on how you make that diagnosis, and it looks like the diagnosis criteria or the diagnostic criteria keeps changing depending on where you are and what you're doing. So what is happening in gestational diabetes is that there are all these placental hormones being produced. There's a lot of cortisol in the circulation. There's human placental lactogen. There are all these progesterones. All these hormones make the tissues in the peripheries, fat, muscle, resistant to insulin. So the placenta has to the pancreas has to produce more and more insulin because there's insulin resistance in the peripheral tissues, and this is done by the placenta so that there is blood sugar available to the fetus in circulation. So this blood sugar that is increased in circulation is there so that the fetus gets some glucose for growth and other functions. So sometimes this can be exaggerated, and this blood sugar goes way above the region of normal. And this region of normal is not well defined, but it's somewhere between 5.1 and 5.6 millimoles. So once the blood sugar goes beyond this window, there's increased risk of fetal morbidity and mortality. So we have this hyperinsulinemia that can result in several problems like respiratory distress syndrome, because the type 2 pneumocytes are not able to produce surfactant because of the increased glucose and because of the hyperinsulinemia. There's increased risk of miscarriages, stillbirths, hypoglycemia in the neonate, polycythemia. There's increased risk of type 2 diabetes in adolescents that were born from a mother or gestational diabetes. There's increased risk of obesity as well. The mothers have an increased risk of cesarean section, and they have an increased risk of gestational hypertension and preeclampsia if this condition is not treated and controlled. So those are the risks that can happen to the fetus and the mother in case of gestational diabetes. So patients with gestational diabetes don't have any symptoms, so they are usually caught through a screening system. This screening system can be different depending on where you are. You have what is called the universal screening, and you have what is called selected screening. So in universal screening, what happens is that every woman gets glucose tolerance test, and then this diagnosis of gestational diabetes is made. So women are screened. Those who have risk factors are screened on their first antenatal visit, and the diagnosis is made, and women who have no symptoms are screened somewhere between 24 and 28 weeks. The important part about universal screening is that everyone gets screened. Every patient who has this condition gets diagnosed, and their risk of morbidity and mortality, especially for their fetus, is decreased. On the other hand, we have what is called selected screening. Selected screening, which is what we normally do in our setup, is that when a woman comes to the antenatal clinic, we take a history and we look for risk factors for gestational diabetes. That is obesity. We look at previous stillbirths. We look at the family history of diabetes mellitus. We look at that woman who had a baby that is above 4.5 kg. We have that woman who had gestational diabetes in a previous pregnancy. We have women who are above 35 years. We have women who had polycystic ovarian disease. All these women are at risk of developing gestational diabetes. So these are the women we do that fasting blood sugar for. So we do a fasting blood sugar and decide, do they have gestational diabetes or not. That is what we normally use. A random blood sugar is not very useful in making a diagnosis of gestational diabetes. So the key thing would be that fasting blood sugar. There's a lot of debate on the timing of screening, but we need to do this screening somewhere between 24 and 28 weeks. There's debate on what is the sugar that we should make a diagnosis of gestational diabetes on. The debate is there because there's no one sugar where everything goes wrong. The place where the sugar goes wrong is a range. So everyone or someone defines gestational diabetes at a sugar level depending on resources to do that sugar level, resources to treat patients who you find with gestational diabetes, and so on. So that is how the level of sugar is normally picked, on which we'll call patients as having gestational diabetes or not having gestational diabetes. So how do we make a diagnosis of gestational diabetes? So we make a diagnosis of gestational diabetes by doing what is called an oral glucose tolerance test. The recommended one is what is called the one-step 75-gram oral glucose tolerance test. So you give a woman 75 grams of glucose, and then you do sugars at 1 hour, and then you do sugars at 2 hours. And you can also have a record of her fasting blood glucose level. That is blood glucose that you do when someone has not eaten for 8 to 10 hours. That is what is called the fasting blood glucose. So according to NICE, when we have a 2-hour glucose level of above 7.8 and we have two of these abnormal values, we make a diagnosis of gestational diabetes. If we have fastings that are above 5.6 and we have at least two of them, we make a diagnosis of gestational diabetes as well. And I think this is much easier in our setup where we might not have glucose to give the patient to make this diagnosis, this 75 grams. And normally it's better to use, it's easier for us here to just use a fasting blood glucose. Once we see 5.6 and above, then we make a diagnosis of gestational diabetes. I put this slide, the other slide, just to compare how we make a diagnosis of pre-gestational diabetes mellitus, fasting of above 7, or random blood sugar of above 11.1, or a glycosylated hemoglobin of above 6.5% would make us diagnose a patient when they are not pregnant as someone who has pre-gestational diabetes mellitus. So how do we treat gestational diabetes mellitus? So we normally start with diet, and the diet should be predominantly carbohydrate and ideally complex carbohydrates. So a complex carbohydrate means that those carbohydrates with low glycemic index, meaning that they are complex carbohydrates. So millimole worse than the actual maize cob, a guava fruit much better than guava juice, the actual orange fruit much better than orange juice, and so on. So the more processed the food is, the easier the sugar goes into the blood because it's partly processed, and therefore the higher the sugar gets into the blood, the higher the postprandial glucose, the more the morbidity for the fetus. So our diet should be predominantly carbohydrate, about 50%, and then the rest, maybe 25 would be like fat and protein. And we know protein is expensive to come by, and so we don't have most patients, a lot of people having a huge portion of their diet with protein. And of course fruits and fresh vegetables make a significant contribution to helping in this glycemic control. In all patients, exercise is useful to lower blood sugar. So we do exercise that's not dangerous for the patient, and usually every other day for the week. Those who are obese would need to reduce their weight a little bit, and this might help with glycemic control in the peripheral tissues. It's important to realize that a strict blood sugar control is important. For fetal morbidity and mortality, the issue is that the sugar needs to be strictly controlled. The type of diabetes is not really the issue. It doesn't matter whether you have pre-gestational diabetes or you have gestational diabetes. The morbidity of the fetus really depends on glycemic control and not on the type of diabetes you have. So the sugar should be at least in between 4 and 6 millimoles, and then we have a good sugar control. 1 hour postprandial glucose level should be around 7.8 or below, and we need to remember that when we give dexamethasone, sugar control will be disturbed for almost 72 hours, so we would need to increase the dose of insulin to uh, to counteract the effects of the steroid that we've given. In the antenatal period, anomaly scans, especially if the gestational diabetes has been diagnosed early, should be done around 18 to 20 weeks. And because of the effect of diabetes on the placenta, it's important that these patients get through growth scans every month from about 28 weeks in our setup to monitor the growth of the baby. If the diabetes has not been controlled by diet and exercise, we need to go into drugs. And the gold standard for the treatment of gestational diabetes mellitus once it's diagnosed is really insulin. But there's increasing evidence that metformin is really very close to insulin in terms of control and morbidity, reduction in morbidity for the fetus if it manages, if metformin gets the sugar controlled. So studies have been done that show that metformin is comparable in terms of hypoglycemia for the fetus, respiratory distress syndrome, birth trauma, APGAR scores. All these parameters look very similar in those who receive insulin and metformin. If insulin does not control the sugar, what we need to do is ideally add if metformin does not control the sugar, what we need to do is add insulin to it. So it's been seen that insulin alone is actually worse than metformin and insulin. So it's important that once metformin fails to control the sugar, we can add insulin, and this is a good combination of drugs to control the sugar. It's only when it's not possible to use insulin plus metformin that we can choose glibenclamide and metformin. So glibenclamide is really the least superior drug of these hypoglycemic drugs. So we only use it when it's not possible to use insulin for various reasons, the type of patient, the cost, the logistics. Then it's better to have a good sugar control with metformin and glibenclamide if it's not possible to use insulin. So timing of delivery is another issue we have to deal with. If sugar is well controlled in this gestational diabetes patient, we can usually wait for spontaneous labor. We can usually wait for spontaneous labor to start, but no one is really willing to wait beyond 40 weeks when you have a patient who you've made a diagnosis of gestational diabetes. Induction of labor, if everything is okay, should not be done before 39 weeks. This is because we know because of hyperinsulinemia, fetal lung maturity is impaired because the type 2 pneumocytes function is maturity is delayed because of hyperinsulinemia and hyperglycemia. So we need to make sure that if we are going to do induction of labor, and there's no compelling indication to do induction of labor, we should do it at 39 weeks. Induction, of course, can be done earlier than 39 weeks if sugar has been difficult to control, if a mother has had previous fetal losses, maybe if she's had a fetal loss at 37 weeks, maybe you want to even do that induction a bit earlier, depending on the history, so that can be worked on. So when labor starts spontaneously, in that patient whose glucose has been well controlled during the pregnancy, there's really not so much to do. So if labor starts spontaneously, we just need to remember that during the latent phase, we continue the drugs as usual because there's nothing much happening. Usually the liver has enough glycogen to give this woman enough glucose as she's going through the latent phase. Once a woman gets into the active phase, we need to remember that they are at risk of hypoglycemia. They're at risk of hypoglycemia because labor is labor, so it uses up all a huge amount of glucose, and therefore these women are going to be at risk of hypoglycemia. That's what we need to be aware of. So we need to do blood glucose levels more frequently when the patient is in the active phase of labor. Depending on the particular patient, we can do it hourly, we can do it 4-hourly, we can do it 6-hourly in the active phase of labor. The important thing to remember is that the glucose levels really go down during the active phase of labor. If a patient has needed insulin during the antenatal period, usually they would need an insulin infusion in the active phase of labor and the glucose. So you put insulin on one drip and you give somewhere in between 0.5 international units to 1 international unit per hour for this patient, and then there's a 5% glucose running on the other drip, and you keep balancing them to have a glucose level during labor during active labor of somewhere between 4 and 6. We need to realize that a lot of risk for hypoglycemia in the fetus happens if glucose is poorly controlled in the 4 to 6 hours before delivery. So this is important, but the take-home point here is that most patients who had their glucose levels well controlled in the antenatal period will not need a glucose and insulin infusion. It's those patients who were on insulin, and usually those patients who needed around 60 international units of insulin per day. Those are the ones that will need this infusion. Most other patients will just continue on their medication as the labor progresses, only remembering that there's a risk of hypoglycemia once the woman goes into the active phase. So we continue monitoring the sugars as appropriate, individualized, until the woman gives birth. Once the woman gives birth, we need to remember that because the placenta is out, there's no human placental lactogen, all those placental insulinase enzymes are not there anymore. So these women with gestational diabetes, we might need to stop insulin there and then. If they needed insulin, we might need to stop oral hypoglycemic drugs if they needed oral hypoglycemic drugs, and then we keep monitoring the sugars and deciding if they need to get their insulin to be continued, or their oral hypoglycemic drugs to be continued. So if elective C-section is going to be done for any reason, maybe macrosomia or whatever reason it's going to be done for, it's important that the patients take their usual doses of these hypoglycemic agents, whether it's oral or insulin in the night. They take the usual doses. It's important to remember that these deliveries should be done very early in the morning so that we prevent the risk of ketosis. If the woman is kept starving for a long time, she'll go into ketosis and those complications. So it's better to do these procedures early in the morning. We need to remember that when a woman is having a C-section, that is a high stress on the physiology. She might have hyperglycemia, which will lead to hypoglycemia in the fetus, and a lot of fetal morbidity. So it's important that sugar is monitored during cesarean section and after cesarean section hourly until this woman starts to feed. Just like a normal delivery, it's important to remember that once the placenta is removed, the needs for these hypoglycemics go down, and in gestational diabetes, we need to remember that usually these patients will not need any hypoglycemics after delivery, and they need to be stopped. It's the same as inductions. They need to also be done as early in the morning as possible. So the issue of an infusion and of glucose and insulin really applies the same way as it applies in the patient in the active phase of labor. So you give these medications, glucose and insulin on the other drip, especially again for those patients who needed insulin during the antenatal period. For the patients who did not need insulin in the antenatal period, they will very likely not need insulin, and what is needed is close monitoring and giving appropriate treatment as needed for that particular patient. So we've already talked about how the need for hypoglycemics reduces immediately after delivery because the placenta has been delivered. We need to remember that we need to encourage breastfeeding because breastfeeding helps in sugar control because breastfeeding needs a lot of energy. There's the need for hypoglycemic drugs reduces, and also we need to know that there's a risk of hypoglycemia as well during breastfeeding. We will still need to continue monitoring the sugars as a woman is breastfeeding, and we will individualize at what point we stop these hypoglycemic drugs or insulin. The last point is that it is protocol in some institutions to admit all babies born from diabetic mothers to NICU, but it's important to just realize that the main issue is early breastfeeding. You breastfeed the baby within 30 minutes of delivery, and then the baby needs to be fed every 2 hours thereafter. Then we reduce the risk of hypoglycemia. There's need to get a blood sugar from the baby after birth to just get the levels of sugar in this baby as well. Yeah, so we need to remember that these patients are usually taken care of in a high dependence unit. Once their sugar is controlled, their baby is okay. After 24 hours, they go to the postnatal ward. And in the postnatal ward, they will usually stay another day before they get to be discharged. They might after discharge, they will go to they will come for a postnatal visit at 6 weeks, and will do sugar again to check if they are still hyperglycemic. So because most of the patients with gestational diabetes are at risk of type 2 diabetes mellitus, so at the 6 weeks visit, we need to check for sugar, and if it's normal, that can be done yearly because again these women are at risk of developing gestational diabetes early in life. For those ones who need oral hypoglycemics after delivery and for a few maybe weeks after discharge, it needs to be known that these are safe and they can be taken with breastfeeding. It's important to discuss contraception for these women so that they don't fall pregnant early, because they would need to plan for their pregnancies and also have their sugars checked before they become pregnant, because hyperglycemia early in pregnancy is a risk for congenital abnormalities and chromosomal abnormality issues. So it's important that contraception is advised for these women after they have been discharged. So this was our presentation on gestational diabetes. Thank you so much for listening, and we will see you next time.